We will now proceed with managing traumatic brain injury. TBI is managed within the ATL's initial assessment, starting with the primary survey. The initial assessment and primary survey are the most important parts of the management of TBI. If the initial assessment is not done well, CT scans and craniotomy will not be relevant. This study is from Uganda. The intent, age, gender, causes and distribution between unintentional and intentional is similar throughout Eastern Africa. 70% of TBIs are unintentional, 70% are young people, and 80% are male. Monitoring alternations in consciousness, cognition, and neurological signs is mandatory. TBI mortality doubles when it is associated with hypoxia or hypotension. Timely airway and ventilation management is critical to prevent hypoxia-related complications. Shock management, fluid resuscitation, and hemorrhage control are essential to improve outcomes. Ensuring a patent airway, adequate oxygenation, and hemodynamic stability are foundational to TBI patients' care. Continuous monitoring and assessment to detect evolving symptoms or complications is required. The initial management of a trauma patient starts with the primary survey. Airway, breathing, and circulation are critical. Life-threatening conditions must be promptly identified and addressed. Any patient with severe traumatic brain injury should be considered as having cervical spine injury unless ruled otherwise. The airway must be patent, and at the same time the cervical spine should be immobilized. Oxygen must be provided to keep the oxygen saturation greater than 90%. Oxygen concentrators can be considered. Airway compromise and hypoxia can cause altered mental status due to hypoxic secondary brain injury. Airway should be kept patent. Any foreign body in the airway should be removed, and secretion should be sucked out. The commonest cause of airway obstruction in unconscious patients is a fallback of the tongue, which should be prevented by applying jaw thrust and chin lift. Intubation may be required to support and maintain adequate oxygenation and ventilation. Severe TBI patients should be intubated immediately to ensure proper oxygenation and ventilation. Moreover, intubation and hyperventilation help treat increased intracranial pressure by increasing the partial pressure of oxygen in the blood and decreasing the serum partial pressure of carbon dioxide. Intubation helps protect the airway from aspiration of gastric contents or blood. Mechanical ventilation allows control of oxygenation and ventilation. Intubation and controlled ventilation can help manage ICP by maintaining stable arterial carbon dioxide levels. Ensuring that the patient receives the necessary oxygen and expels carbon dioxide is crucial for preventing secondary brain injury. Intubation can provide a controlled environment for frequent neurological assessment. TBI impairs a patient's ability to maintain their airway, leading to airway compromise and respiratory distress. The respiratory control center in the brain stem is impacted indirectly through raised intracranial pressure, ICP. Monitoring blood pressure and pulse can help identify signs of shock. Hypertension must be urgently rectified. A pulse oximeter is affordable and very helpful. Traumatic brain injury by itself does not cause hypovolemic shock. Scalp lacerations with torrential bleeding should be stopped immediately, as they can be a cause for shock. Otherwise, in the absence of any scalp lacerations with bleeding, we should look for other sites of bleeding causing shock, such as hemopneumothorax, long bone fractures, or hemiperitoneum. Maintaining appropriate fluid balance is crucial in managing head-injured patients to optimize cerebral perfusion and reduce the risk of complications related to an intracranial pressure. Normal blood pressure maintains adequate cerebral perfusion and avoids excessive intracranial pressure. Ringer's lactate or saline solutions are isotonic, and therefore do not cause shifts of fluid into or out of brain tissue. Dextrose solutions can cause cerebral edema and worsen intracranial pressure. Hypoglycemia must be treated, but it is essential to avoid hyperglycemia as it may exacerbate brain injury. The Glasgow Coma Scale of TBI patients should be assessed and patients classified according to the severity of TBI. Pupillary size and reactivity should also be assessed together with the motor examination of patients. The neurologic exam helps determine the side of the intracranial bleedings and other associated traumatic lesions in the brain. A VPU is a quick and useful tool for initial assessment, especially when time is of the essence, such as during emergency care or triage in trauma scenarios. It should be taught to frontline health workers. A. Alert is a minor injury. V. Vocal is a moderate injury. P. Pain is severe injury. U. Unresponsive is a very severe injury. Exposure must be done while maintaining patient privacy and dignity. Maintain body temperature. Prevent hypothermia or hyperthermia. Use blankets or clothing as necessary. Remove hazards in the patient's environment. Note: bruising, bleeding, rashes, or other abnormalities, which may be signs of serious underlying injury. Next is a head-to-toe exam and ample history. But if the patient deteriorates at any time, you must return to the primary survey, re-evaluate a BCDE, and respond to any deterioration promptly.